there to you all. This is Jean Abbott. This module is going to be about two core concepts in ethics that apply to medicine in general: confidentiality and truth-telling. I've broken up the talks into actually three different sections. First, on this module, we're going to talk about confidentiality in medicine. Then we're going to talk about truth-telling in the second talk. The third talk is some evidence and recent studies that might be of interest to you. If they aren't, you're welcome to skip them. But we will then follow with a case for you to develop, one of two. And I hope you have fun with this module. It's important, and I had fun writing it. In this first set of 11 slides, I'm going to address privacy and confidentiality. These are two important concepts and really cornerstones of the way that we interact with patients. Privacy is that principle of the patient being able to control information about themselves. There's physical privacy, protection from being touched without permission. There's the privacy of freedom of choice. There is, all of this is constitutionally supported, a zone of these private decisions and actions with which the government and other people cannot interfere. Out of that control of personal information comes our HIPAA legislation that I'm sure that we are all aware of. In addition, privacy says yourself and parts of yourself cannot be used for other purposes. We can't take pictures of you without your permission and post them on Facebooks. And we'll talk a little about Henrietta Lacks in just a second. You probably have heard her story. In contrary, confidentiality is the patient's right to control the physician's sharing of information. Healthcare providers can't reveal patient information without the patient's consent. This goes back to the Hippocratic Oath and the AMA Code of Ethics, although right now there are new challenges to confidentiality due to the fact that people see multiple people in the hospital. They have an electronic medical record that is accessible to anybody with a badge in our hospital. And we oftentimes get into trouble when we chat about patients in the elevator or in patients' rooms or in the ER when there's only a curtain between rooms. I want to start with the story of Henrietta Lacks. You may have read the book that has been an important one called The Immortal Life of Henrietta Lacks. Henrietta was an African-American, poor American in Baltimore. She was born in 1920, and she developed cervical cancer, which she presented with very late. With metastases. She had attempted surgery and biopsy with some tissue removal, but physicians were unable to cure her or give her more than palliative surgery, debulking, and she died shortly after the surgery in 1951. One of the researchers who looked at her tissue after the biopsy and the surgery noticed that her cancerous cells were unusual because they multiplied many times without dying, which is the usual thing that happens with cells that are taken out of the body. So more cells were taken after her death during the autopsy, and among those cells which were developed into a cell line, they developed an extraordinary cell line that multiplied many times, had consistent growth that the researcher, George Guy, noted and allowed a large number of experiments. In fact, as the plaque near her home says, these became the gold standard for cell lines, were widely distributed, and were the origins of Jonas Salk's polio vaccine, were used to develop cosmetics. They were used a whole lot of places where researchers needed a reliable cell line to do experiments on the effects of various treatments and drugs. These were the first successfully cloned human cells, and they were put to incredible commercial use, with an estimate in Wikipedia that 20 tons of her cells were distributed to researchers around the world. There were 11,000 patents generated by the research that used her cells. Interestingly enough, the family, there was some contamination to the Gila line along the way in the 1970s. Remember, she died in 1951. And so people called up the family and said, hey, could we get some of your blood samples and maybe even some tissue, because something's happened to our line with Henrietta, and since you're her relatives, we figure you must have similar characteristics to your cell lines. Well, the family was a little bit perplexed and started asking questions about this, started to learn about the distribution of her cells, and actually in 2013, her whole DNA genome was published in Germany. All these things happened without consent of either her or her family, and frankly, that was not common at the time. But the big question became a privacy one. Can discarded tissue be commercialized, or does it belong to the patient and the family? Ultimately, negotiations have happened over the HeLa cells. The NIH gave the family some control over access to the cell lines, and 2 family members now are seated on the committee that regulates access to the genetic code, which was made from her human cells. So Henrietta's story is one that highlights some of the increasingly complex privacy issues in modern medicine. And it is linked arm in arm with the concept of confidentiality, the physician's obligation not to disclose information given to her or him by the patient without their permission. Why do we have confidentiality? Well, we think that it shows respect for the patient. It gives the patient autonomy and respects their right to control their body. It's loyal, and it nurtures a trust relationship. And it is hoped that that trust relationship will allow the patient greater comfort at revealing important information that we may need to have. So confidentiality is actually a cornerstone of the provider-patient relationship in all settings. There are important exceptions to confidentiality, and I'm sure you've run across them in your practice. First one is when there is a more important right of somebody else that's at stake. So protecting third parties are an important exception to confidentiality when there is imminent threat to the safety of another or of the patient themselves when they're suicidal. If there are injuries that are caused by weapons that are might be involved in crimes like gunshot wounds, etc., I have an obligation when working in the emergency department to report that. If a psychiatric patient is violent, that needs to be reported. And in addition to the trauma kinds of threats are the public health and safety considerations. Infectious diseases, particularly sexually transmitted diseases, require partner notification, and impaired drivers, although that kind of reporting varies from state to state. The second important category of exceptions are when there is a more important right of the patient themselves at stake. This is particularly true with vulnerable patients. So elder abuse, child abuse, and domestic violence are all reportable exceptions to confidentiality. We'll talk a little about imminent threat of safety to another, but highlight the fact that this is a very limited exception to confidentiality. The Tarasov case is one that you will hear. It's a classic bioethics case that you should know about, even though it isn't particularly related to palliative care. There was a grad student from Berkeley, Tatiana Tarasov. In 1974, she was a grad student there, and she met up with a gentleman named Podar. They were both grad students. His feelings for her were greater than hers. Oh, surprise, this is always an unequal situation, or frequently at least. And he began stalking her. He became extremely distraught, and he confided to his psychologist that he was going to kill her. The psychologist notified the police. The Mr. Podar was detained, and then he was released by the police after questioning. Actually, Tatiana was not in the country at the time. But several months later, when she had come back to Berkeley, he carried out his plan, stabbed and killed her. The psychologist was convicted on the basis of not having warned Tatiana of the threats. That conviction of the psychologist was eventually overturned. Podar himself, who had murdered Tatiana, was released in exchange for returning to India. Good grief, I'm not exactly sure how that happened. But the California Supreme Court found that a mental health professional has a duty not only to a patient, but also to individuals who are specifically being threatened by that patient. This decision has been adopted by most states, and it's influential even outside of the United States. And the key finding in their ruling is that the protective privilege ends where the public peril begins. Now, that's a very general statement, way too general. What is important for all providers to know is that if there are specific threats by a patient against a specific person that seem plausible, that must be reported. And you are protected if you report. It's not the general thing that we hear, I'm going to shoot up somebody, I'm so pissed, that kind of thing. It's, I'm going to shoot my girlfriend when she comes back home with the gun that I have in the garage, kind of thing. So there is a gray zone, as there is with many things, but that is what the Tarasov case is all about, and you will continue to hear about it in your professional life. The challenges to confidentiality have exponentially increased recently. The number of people who go in and out of your room or are providers or consultants or clerks in hospital facilities is in the double or triple digits. Electronic medical records have allowed internal access for many people, and external access for insurance companies and employers. And of course, the huge problem that we're learning about on a daily basis of hacking. HIPAA, the Health Insurance Portability and Accountability Act, was started in 1996 to protect patients and assure that their medical records would be portable and protect them from insurance denials. However, there have been some abuses and some myths associated with HIPAA. I don't know whether you ever run into the problem that I sometimes do, which is you ask for some information about a patient, particularly on an outpatient setting, and some clerk says, no, I'm sorry, we're not allowed to do that, to give that to you without written consent from the patient. Well, that's baloney. That is a misuse of the understanding of HIPAA. But the problem of who to share information with between families and among clinicians is a difficult one as we try to get a balance between enhancing person's health and protecting their privacy. So how about when we're dealing with disclosure to others? This can be a real problem. We often assume when family and friends approach us in the hallway and ask about what's going on with their loved one, we assume that they are in good faith and that we are allowed to share information unless the patient has told us otherwise. Patients with decisional capacity are allowed to limit access and say, I don't want this disclosed. That could sometimes cause some dilemmas when they don't want even to disclose who would be their decision maker if they lack capacity. And then When patients do lack capacity, the proxy decision maker, whether it's an agent with the MDPOA, whether it's a surrogate of another stripe, they control the release of information. So our job is to disclose to the proxy what we would disclose to the patient, and they can decide whether to disseminate it, and it's in the interest of disclosure to family and friends. How about for VIPs? Oftentimes there's a lot of interest in VIPs and what's going on with them. You may remember during the 2016 campaign, everybody wanted to know whether Hillary had a pneumonia at one point. What about limiting that kind of information? We do not release that without the permission of the patient. In the hospital, when we have a VIP, we oftentimes use initials for their name on the board by their room, just to protect them and keep nosy people out who might be coming in. And again, oftentimes a public person will ask that the information disclosed about them, or even the fact that they're in the hospital, is limited. Medical records also has issues with disclosure, and we often run across, as you will in palliative care consults, with the omission of sensitive information. This is an ethical dilemma. Should we note in the chart that the patient had suicide attempts, what their HIV status is, even a diagnosis of cancer? Psychiatric disease, major depression, can be a risk to the patient when disclosed to insurance companies or to employers. This is a little bit better because of laws that now prevent a bias in insurance about pre-existing conditions, but there's still biases that are subtle in society that make disclosing sensitive information a really hot topic. Remembering that the medical record goal is to enhance patient well-being and quality of care, that is a huge dilemma because it requires transparency. And you for your palliative care consult, me for ethics consults, me in the emergency department. It's sometimes frustrating to not know how disabling somebody's psychiatric disease is because psychiatric records are kept from the main medical record. And it would help us as we're trying to aid the primary practitioners. So this is a really tricky field. One of the options you have for your written assignment today is to talk about how you would disclose HIV status on Caleb, for instance. This is a serious argument that goes back and forth for many of us in the ethics community and for you as providers. The arguments to disclose HIV status are, number one, it socially normalizes the disease. This is a disease that carries stigma the more we keep it silent. And to talk about it as a chronic disease like diabetes actually helps to normalize the fact that normal people get HIV infection. It's important to avoid risk to the caregivers, although we've developed principles that say everybody should universally protect themselves from patient contamination. It's important for partners to get tested. And frankly, either for the patient or if they aren't able to make decisions for their surrogate, it oftentimes can be an extremely important element of the decision making for a seriously or critically ill patient. On the other hand, we live in a society that has biases against patients and people with HIV disease. We need to respect their privacy and confidentiality. And I actually got my best teaching from an infectious disease colleague who said, you know what? Patient relationships are extremely important, particularly when you have a chronic disease like HIV. And it is best if we let the patient disclose when they're feeling better. Because frankly, there's not a risk of transmission while they're in the hospital. And it's not as acute and emergent as my interns would think, as they call us up and say, oh my gosh, we've got to be able to disclose to the wife that this patient is HIV positive. You know, the tempo of that is less urgent than most people think. Now, if you really want a challenge in your written discussion, I'm going to tell you about a dilemma that I had a few years ago. And at the end, I will tell you, at the end of the week, I will tell you what I did. And I'm not particularly proud of it, but let's see what you do with it. So a few years ago, we had a woman in her late 30s. She was from Florida, and she was a long-distance truck driver. She and her boyfriend drove delivery trucks, commercial trucks, all around the country. They were on I-80, and she got pneumonia in Cheyenne, and she was admitted there. But she signed out AMA, still very sick, with a working diagnosis of PCP pneumonia. She rolled into Denver and presented herself at the door of our ER in Denver and was in severe respiratory distress. She needed to be intubated at that point. She had big cystic blebs from her PCP on her x-ray. And just before she was intubated, she said to the providers, "Don't tell my boyfriend I'm HIV positive." Now, the boyfriend was the only one available to make decisions. He spoke Spanish only. And he was loyally by her side on a daily basis while she was in the intensive care unit, getting worse and worse. She blew blebs, she needed chest tubes, and we got an ethics consult actually 30 days into this as she was dying on the ventilator. Everybody had honored her wish to not tell her that she was HIV positive, but the boyfriend is now making decisions, and the team called us to say, can we tell him? How are we going to help him? Because she's actually dying of this. So, if for your little discussion, you'd like to help us all by saying how you would approach this, I'm going to leave that with you hanging and see what you have to say about it if that's what you choose to do for your written assignment. So I'm going to take a break now, and we'll get back to truth telling in another set of slides. Thank you.